presentations lecture 1, abnormal involuntary movements. Okay, so generally when we talk about involuntary movements, we're talking about movement disorders. And I'm a movement disorder specialist and I do this a lot. So we tend to mean this as pathological movement which shouldn't take place. People do have some movements which we don't intend to make, but we call those autonomic or reflex movements. An example might be a hiccup, which is an automatic movement. A reflex movement might be when you put your hand on a hot surface and you quickly pull that away. That's a reflex. Sometimes involuntary movements are tied up with epileptiform movements or seizures, and that can often be quite a diagnostic conundrum. And we also talk about sort of non-intentional or partially intentional movements, which again are usually not pathological, things like stereotypies, which you might hear about in paediatrics. So first off, the most common movement disorder you'll see is tremor. Now, tremor is usually seen as part of a hypokinetic movement disorder. So there is overall reduced level of movement. People are stiff and slow. It's an oscillatory, regular, rhythmical movement. It can be coarse, i.e. very slow, or it can be fine. Coarse movements tend to be coarse tremor tends to be associated with Parkinsonism or Parkinson's disease being the most common one. And we always say that has a frequency of about 4 hertz. Don't worry about it. You will, with time, if you do lots of neurology, you'll recognise the sort of cadence, the rhythm that a Parkinsonian tremor has. Other features help identify what kind of condition the tremor is attached to. So a pure tremor, which is action determined, tends to be an essential tremor with no other features. If you're stiff and slow, maybe have balance problems and other non-motor symptoms, you think of Parkinson's disease. And if you tend to have a tremor in certain postures, that could be a dystonic tremor. All of us have a tremor to some degree, which is physiological. When we're alarmed or when we're cold, we have a tremor, and that can be enhanced by other factors such as medication. So salbutamol inhaler or caffeine can cause a worsening tremor. And of the hypokinetic movement disorders, we tend to talk about Parkinsonism, and I think of that as an umbrella. And under that umbrella, you have the family of hypokinetic movement disorders. By far the biggest is Parkinson's disease, but then we have other rarer forms, drug-induced, metabolic, vascular, and then we have sort of what we call atypical Parkinsonism, multiple system atrophy, Lewy body disease, corticobasal syndrome, progressive supranuclear palsy. But within their core, they all have Parkinsonism. So they have slowness or bradykinesia, stiffness, they may have tremor, they may have postural instability, and other features. Hyperkinetic movement disorders, so these are movement disorders which are fast, there is too much movement. And the way to think about these is in a spectrum. So I've shown you here a sort of a continuum of movements, and at the one extreme we have athertosis, that is a sort of slow sinuous movement, and typically that's described in cerebral palsy, but you can see it in Huntington's disease. And people talk about it like a sort of undulating snake-like movement, particularly of the hands. Dystonia, a little bit faster, that tends to be an abnormal posture, which can be fixed, maybe associated with the tremor. Chorea, that is a sort of dance-like semi-purposeful movement, I'm almost doing it myself now, where people sort of turn their sort of excess movement into partial voluntary movement. So they may sort of brush their hair or sort of adjust their posture. Restlessness it is how it comes across. And you may find if you're in a room with someone with chorea and it's subtle, you yourself feel a bit restless, and that's what you need to look out for. Ballismus, so we think about hemiballismus as the most common thing that we tend to see, and that is a sort of flinging, ballistic means throwing, ballistic kind of movement of the arm or leg. And you can see that with, for example, strokes in the basal ganglia. Tics are very sudden movements, which can be seen as part of things like Tourette's and pediatric disorders, and they can be either simple movements or they can be vocal or sounds and speech, really. So people can have sort of involuntary speech or just sort of coughing sort of movements. And myoclonus is the fastest. It's a very sort of sudden, sharp jerk. A myoclonic movement of the diaphragm is your hiccup. You may also get things like toxic myoclonus with drugs where people are sort of jumpy. And I've talked about all of that here. So I've got some brief videos here, very, very brief, which I'll show you. So here you'll see a lady with myoclonus, this sort of jumping and jerking there, and this was drug-induced. And here we'll see a lady who has cervical dystonia, so her neck is sort of fixed in an abnormal posture, and she also has a tremor associated with that. And cervical dystonia is very, very common, and you may also see sort of posturing of the hands in this sort of situation with tremor of the hands. And that's important to look at if somebody has a tremor. Do they have these abnormal turning, twisting postures that would help you identify the cause? So we briefly talked about other involuntary movements. So focal seizure activity obviously is an abnormal involuntary movement, and it may be mixed up with a movement disorder. So some people can have a seizure which affects one side of the body, for example, an arm or a leg or both, and they may have retained consciousness. So that can be tied up with, is this an unusual tremor? Particularly if somebody, for example, has learning disability or is unwell and you can't ask them. And automatism is, again, a sort of an automatic movement which we often think about as part of a seizure. So people can sort of smack their lips or fiddle with their fingers before they have a temporal lobe seizure. Asterixis is a posh word for negative myoclonus. So if people have liver disease and they have metabolic encephalopathy, hepatic encephalopathy, because they've got lots of ammonia because the liver isn't cleaning it out, ask them to flex back their wrists and they'll get this sort of drop as they're unable to sustain the posture. That's negative myoclonus or asterixis. And a stereotypy is a bit of a funny one. It tends to be a self-comforting, repetitive movement that we see quite a lot in very young children who are distressed, and it may be preserved, particularly in people with learning disabilities as they get older, kind of a rocking, sort of self-comforting kind of movement. Head banging, that is the sort of thing that you tend to see. And if you tend to see it in the context of someone who's distressed or in pain, and they then this movement then appears, you can infer that this is a sort of comforting, self-reassuring stereotypy for somebody who may not be verbal and may not be able to communicate their distress. So, in summary, involuntary movements is a very, very wide subject, but we tend to think of it as movement disorders, which are to do with pathology of the basal ganglia, and we have a division between hypokinetic, too little movement, and hyperkinetic, too much movement. Within hyperkinetic, we have a spectrum of how fast that extra movement is. Athetosis tends to be the slowest, myoclonus the fastest. Sometimes focal seizures can be mistaken for a movement disorder or an unusual tremor, or the reverse. Things like tremor and myoclonus can result from general medical issues, and I'll sort of prompt you to think of things like thyrotoxicosis, which can cause a tremor, or hemibilismus, which can be caused by a stroke, for example. So I hope that's given you a good brief, and see you next time.